So what do we need to know for the clinical interpretation whenever you receive a result that is an anti-drug antibody result, either in the clinic or from clinical trials? Anti-drug antibodies are antibodies to drugs. Antibodies are the humoral immunogenic response to therapeutic drugs. And for more details, part one of this series is the general principles for the clinical interpretation of immunogenicity. So I talk in detail about what do I mean by humoral or B-cell response. This particular anti-drug antibody response is no different than any other B-cell response. It has a primary response, which is basically the first time that your B cells will react to the drug, and a secondary response, which requires adaptive immune system memory. And this is why it's important to interpret what exactly do we have when we get results from anti-drug antibodies. Now, on the other hand, the anti-drug antibodies have the component of the drug. So the drug that is immunogenic could be an endogenous non-antibody protein. I think the best known is probably insulin, but there's a lot of drugs out there that can create an immune response. They're not antibodies. But many of the recent armamentarium for therapeutic drugs include monoclonal antibodies that we engineer to target a specific mechanism of action. And these are antibodies. So the complexity of the thinking of an anti-drug antibody is that your drug could be an antibody. So you have an anti-antibody antibody, and this could become a little bit like a house of mirrors. So just make sure that whenever you are interpreting anti-drug antibodies, in your mind, remember what is the drug your patient received or the population in a clinical trial received, and what was the anti-drug antibody assay? Did it use the same drug or did it use the endogenous protein? What exactly are you interpreting when you get these anti-drug antibody results? Let's take a look at the humoral response timing when considering the anti-drug antibodies. So one of the things that's important is that when you get the results, either from a clinical trial or from an individual that you're following in the clinic, look at the clinical assay manual. When you get the results, there's fine printing of where this test was performed or the assay, and you may have a number you can call for a clinical assay coordinator. Have it handy in case that you need that for understanding exactly what was the test done and how to interpret the results. If this is in a clinical trial setting, you probably already know the clinical assay coordinator and you can have communications with them. Likewise with a clinical pharmacologist, especially because anti-drug antibody levels should always be tested with drug levels so that you can interpret if the anti-drug antibodies that the patient is mounting to the drug is actually decreasing the exposure to that drug. It is important to understand the time of the sample collection. So this particular graph is taken from Abbas et al. And I go over this slide in much more detail in the other YouTube video called General Principles of the Clinical Interpretation of Immunogenicity. But as a reminder, this is what I mean when I talk about time of sample collection. You need to make sure that you're assessing and understanding is this a primary or a secondary antibody response when you get anti-drug antibodies. This is important because the timing, the isotypes, and the titers are different if we're talking about a primary response that can be short-lived and have no consequences, or a secondary response that means you have memory, immunological memory to the drug, and it will have consequences. So when we look at humoral response timing, this particular graph, I go over it in more detail in the General Principles of Clinical Interpretation of Immunogenicity YouTube video. but a simplified version of it is shown on the right. So what you see here is that basically when you have a result, you need to understand the isotype and titer. It's not really that difficult to infer if it's a primary or a secondary response. So if you see, when we look at the isotype and titer, in a primary response, it's going to be primarily IgM. There might be some IgG, but it's a bit delayed. The antibody level is higher than at baseline, and you will actually see a peak anywhere between 5 and 15 days when you are actually going to be able to detect those anti-drug antibodies. If it's a secondary response, what you see here is now the switch to an IgG titer and a significant titer booster result. This is anywhere between 2 and 10-fold higher. It is significant, and that's why it's actually very good that you have at least 2 anti-drug antibody results for a particular individual, because taken in isolation, you don't know if that individual is mounting an immune response with an increase in a titer. You can also look at the levels that are normally reported as within normal levels to have an idea if this is really a significantly high titer or not. In some cases, you may get the isotype, but this is rare. Normally, the anti-drug antibodies are going to be reported as total, so it's a sum of IgMs and IgGs, and that's why it even adds a bit more into the response on how much the titer is going to be critical for you to interpret. Again, if you are looking at these samples anywhere between 14 and 28 days after either the first or the second exposure, you could be missing a primary response. For a secondary response, it will go down, but not as low as you had at baseline. But if this is your only sample for a patient, you might want to consider taking future samples closer to the time of dosing to understand if the patient is having a memory response with secondary titer booster. Now, do you have one or two assays? So why would you have two assays? Well, an anti-drug antibody response to two antigens could be either because you've transitioned. Now that we have several different modalities, you could be switching from one monoclonal antibody mechanism of action to another. So the patient may actually have mounted an immune response to one and now have the other antibody in addition to it. Especially for some oncology indications, we're now seeing combinations of biologics. So you might have two anti-drug antibodies, and for more complex molecules that have bispecific mechanism of actions, you need to consider which is the anti-drug antibody that I'm looking at. Is it to the one specificity or to the other? More commonly, we also have now available biologics that are pegylated. And anti-pegylated antibodies are not that uncommon in general populations. So again, you need to understand if your patient is reacting to the pegylated modality of the drug or to the other piece of the drug, which is the one that has the mechanism of action and the specificity. So how do you interpret anti-drug antibodies when you may have two assays? First of all, make sure that you see what are you looking at when you get anti-drug antibody results. Make sure that the drug is identified. What was the captured drug in the assay? And then consider what happens when you have this kind of response. So I'm leaving the right hand graph, which is the simplified graph for one single antigen over time. What you see on the left is now when we have two different antigens, in this case, two different drugs or two different pieces of the drug. So the first one would be when you have the exposure to A. So let's assume that you get started with a pegylated drug and the person has antibodies to PEG, to the polyethylene glycol. So you might want to get baseline antibodies to understand if the patient has drugs to the pegylated piece of the drug. Then when you look at the titers, you see if it's a primary response to A, which could also be on a setting of getting two different biologics. So you have your first biologic and you get your antibodies to A. In this particular graph, I also want to mention that the blue line combines both isotypes. So it's total amount of antibodies. And what you see here, what I was explaining before, is that when you combine IgG and IgM, you can see the titers increase significantly when you get the second exposure to that first antigen. So if there is memory response to pegylation, for instance, you will get a titer booster. And it's a significant booster. In this particular graph, you can see it's a logarithmic scale. So it is significantly higher when you get that secondary response. And if we compare that to the graph on the right, would be adding up all of the isotypes that could be reacting to that first antigen. Now, during the second exposure, you may have the two antibodies. So you may have started your pegylated drug. And at that point, what you need to understand is the antibodies to the active part of the molecule, or the selective part of your molecule, will be reacting as a primary response. Although here, again, in the left-hand side graph, we have all isotypes together. On a primary response is basically going to be IgM in terms of the isotype, and the titer is going to be lower. So if you have taken into consideration any particular circumstance when you have two drugs, make sure that when you get these results, you get them separate for the two different drugs, because also for the second drug, or the second modality, the titers are going to be lower. So make sure that you don't get all together, or that you are not getting only the response to A, so that you can then manage the responses and understand what's happening in a better way. Thank you for watching. If you enjoyed this video, please like on the YouTube channel. And if you are new to my channel, or you have come back but you haven't subscribed, please consider subscribing to my channel. Thank you very much. I hope this was useful, and see you next time.